Hey everyone, welcome to today's Explainer. We're diving straight into a topic that is literally the backbone of clinical documentation integrity. Today we're demystifying the clinical encounter by clarifying a critical yet super frequently blurred boundary, the line between the review of systems and the physical examination. Mastering this distinction doesn't just make you a sharper clinician or coder, it's the absolute foundation for accurate patient care, compliant coding, and effective revenue cycle management.
Here's our quick clinical syllabus for today. Section 1 covers the ROS versus PE boundary. Section 2 goes over the 14 CMS ROS systems. Section 3 tracks the head-to-toe physical exam workflow. Section 4 breaks down objective clinical grading scales, and Section 5 wraps up with determining E and M examination levels.
Section 1. The ROS versus PE boundary.
You know, the single most common daily struggle for us in CDI is just untangling what the patient says from what the provider actually observes. Sounds super simple, right? But in a fast-paced clinic or hospital environment, these two distinct areas constantly bleed into each other in the chart. So I want you to permanently lock this central question into your brain. Is it a subjective symptom or an objective finding? Look through that lens every single time you evaluate a chart. Answer that accurately, and you've honestly won half the battle.
Let's break it down. The review of systems, or ROS, is a purely subjective inventory. We're talking about past and present symptoms reported, stated, or experienced by the patient. If your patient tells you, "My chest hurts," or "I feel kind of feverish," boom, that belongs in the ROS. Now contrast that with the physical examination, which is entirely objective. These are the hard, undeniable findings physically observed, palpated, percussed, or auscultated by the clinician. So if the provider actually measures a temperature of 102 degrees or auscultates a distinct heart murmur, that is an objective PE finding. Bottom line, the ROS is the patient's story, while the PE is the clinician's hard evidence.
Section 2. The 14 CMS ROS systems. Okay, let's systematically lay out the first half of the 14 specific body systems recognized by CMS guidelines for the ROS. We usually start broad with constitutional symptoms, things affecting general well-being, like a fever or unexplained weight loss. Then we move right through the eyes, ears, nose, mouth, and throat, which is your ENT, cardiovascular, respiratory, gastrointestinal, and genitourinary, both male and female. The crucial thing to remember here? These are the buckets where we document symptoms the patient has actively experienced or currently denies experiencing. You absolutely need both those positive and negative subjective responses for a complete clinical picture.
Rounding out the rest of the 14 systems, we've got musculoskeletal, integumentary, which is just the skin, neurological, psychiatric, endocrine, immunologic, and lymphatic, and finally, allergic and immunologic systems. And hey, quick reminder, a positive response in any of these areas means you've got to dig deeper. You can't just check a box. You have to document the symptom's location, quality, severity, duration, and context, exactly like you would for the history of present illness.
Section 3. Head-to-toe physical exam workflow. So, once that subjective ROS is locked in and the patient's story is fully captured, we shift gears right into the objective physical exam. And this relies on a very specific logical sequence. Think head-to-toe workflow. We typically start with a general assessment, vitals, and skin. Then we move down to HENT and the neck. From there, it's down to the chest for respiratory and cardiovascular, further down to the abdomen and genitourinary or rectal exams, and finally out to the broader structural systems, musculoskeletal and neurological. Now, sure, a provider might alter this physical approach in the room to keep the patient comfortable, but the actual documentation, that should pretty much always follow this chronological top-down structure.
And this is exactly why modern electronic medical record systems are built the way they are. They're literally designed to enforce this exact boundary. By categorizing fields by body system, the software ensures that the clinician's hard observations, things like normal bowel sounds or no jugular vein distension, are logged into specific objective fields. That keeps them safely quarantined away from the patient's subjective complaints.
Section 4. Objective clinical grading scales.
Okay, so just writing down that a patient is weak or has good reflexes, yeah, that's not going to cut it for clinical validity and precision. We need standardized data. Take the standard 0 to 5 muscle strength grading scale, for example. This is hard, measurable data gathered during the neuro and musculoskeletal exams. It scales all the way from a 0, meaning literally no motion or muscular contraction detected, up to a 5, which indicates normal, active motion against full resistance. So documenting a 3 out of 5 instead of just vaguely writing weakness gives us a highly specific, universally understood data point that we can actually track over time.
And we apply this exact same toolkit to reflexes and cranial nerves. For deep tendon reflexes, we use a standard 0 to 4+ grading scale. 0 is absent, a 2+ is your normal or average reflex, and a 4+ means it's hyperactive with clonus. Right alongside that, cranial nerves Roman numeral 1 through 12 need to be explicitly evaluated. Now, it's totally fine to document them as grossly intact if everything's normal, but any specific deficit in sensory or motor function absolutely must be detailed. The whole goal here is transforming a visual observation into standardized, quantifiable data.
Section 5. Determining EM examination levels. So why does this all matter? Well, in the real world, this structured documentation directly drives your evaluation and management coding levels. The sheer depth of that physical exam dictates your final billing tier. Under the 1995 guidelines, hitting a comprehensive level means you have to examine 8 or more body areas or organ systems. Under the stricter 1997 guidelines, you need 18 or more specific bulleted items across 9 or more systems. Here's the kicker. If you blur the lines and accidentally drop patient history into your physical exam section, an auditor will strip those elements right out. Your exam depth drops, and as a result, your reimbursement plummets. It's a huge deal.
To wrap things up, I really want to leave you with this one critical takeaway. Clinical documentation integrity requires an absolute, uncompromised boundary between what the patient reports and what you actually observe. Mastering this boundary isn't just some annoying administrative chore. It guarantees compliant coding, it shields you from devastating audit denials, and most importantly, it paints a highly accurate, clinically valid picture of the patient that ultimately drives much better care. So next time you open a chart, ask yourself, is this a story or is this evidence?
Please like, share, subscribe to Decode Healthcare with Harshal.